I want to first welcome you. This is our first in a series of seminars. Good evening, everybody. Welcome to Neurology and Pain Management. In the next 20 minutes, because I promised to get you out on time, in the next 20 minutes, I hope to articulate to you our approach to the management of chronic pain, and in what way we differ from other places, and in what way we are similar. The management of chronic pain is not something that you would normally associate with acute pain. Acute pain is something you have post-operatively. Your doctor gives you a Vicodin, and in a few days or a couple of weeks after a fracture, you're better. Chronic pain is something you have to live with. It's something that doesn't just leave you. So the question is, what are our goals in this practice? And our goals are to reduce intolerable pain and make it tolerable. We cannot get rid of pain. We could if we put you on a morphine pump and you'd be in a daze. So we could get rid of your pain, but it would do you no good. We always have to balance the side effects of what we're doing with the benefits of what we're doing. Benefit, that's called a cost-benefit analysis. Meaning, whenever I do something to you that's intervention or drug or therapy, I have to weigh the benefit of the possible side effects versus the benefit itself. So if I gave everyone who came into my practice morphine sulfate, they would all be very happy and go out with a smile on their face. The problem is, well, I don't care about addictive if you're 88. Do you? I don't care. Anyone over 85, I say, honey, you don't have to worry about addiction. This addiction will outlive you. So what am I worried about? I'm worried about the side effects of narcotics on the brain. I'm a neurologist after all. And after 5 or 6 years on that dosage of narcotics, you will begin to lose your memory. You will begin to develop what other people would think is dementia, and it would look like Alzheimer's. So I have to weigh, every time I write a prescription for a narcotic, for every patient, what is the side effects of that? So failing the narcotics, what else do we use? We use medications against spasm. They're called muscle relaxants. We use agents to allow you to sleep that are non-narcotics, anything to avoid the side effects. And then when we have a localized lesion, a disc at a particular level, we will recommend therapy, and if that doesn't work, we go to injections. That's what we do in this practice. Pain medication and muscle spasm relieving agents, therapy. Not the therapy that you get in the hospital, which is the rehabilitation therapy that you get after a stroke. That doesn't help you in pain, it makes the pain worse. We do the soft tissue massage, electrical stimulation, ultrasound, that kind of restorative therapy. If that doesn't work, we go to the next level, which would be injections. How many patients end up with surgery in my practice? 2 a year. I consider that a success because I know what happens when you go to surgery. You get dramatic relief initially. And then 2 or 3 years down the road, you come back to me. And now what's the problem? The scar tissue from the surgery. So whatever you do in medicine, you've got to weigh up the side effects of what you're doing to that patient. So that's number one. Number two, living with chronic pain is not just about the pain. It's about the human experience of the pain. So you can have two people with the exact same herniated disc, and one person will say, well, I can live with it. I'm still good. I got a guy who does his cornfield, and it doesn't matter. He's racked with pain. He's got spinal stenosis. Another person with that same spinal stenosis is almost paralyzed and asking for disability. Same spinal stenosis on the same x-ray. What does that mean? Each one experiences pain differently. So it's not like my predecessor who can show a bunch of statistics and say, well, in 50% we had that, and in 50% we had that. It doesn't work like that because pain is subjective. It's not like a seizure. It's subjective. And therefore, the way I experience my pain is as much to do with the pain as any objective test that you may have. Which means I got to listen to you. Most of the time, we're so rushed and so busy, the doctors don't listen to their patients. But if I have a patient coming to me, and let me tell you, there's been abuse when they were a child. A lot of my patients have had abuse. And they now come back to me 20 years later with chronic pain. It's all over. It's not localized. So if I find a bulging disc at L5, I'm going after the wrong thing. Many of them come to me and say, well, I went to this doctor and he did an MRI and it showed this. And they didn't listen to the story of abuse, because we know from the literature that patients who've had abuse in childhood will come back with a multiplicity of symptoms. So if you just go after that L5 disc, you've missed the boat. They'll come back 20 weeks later and say, well, I've got my neck is paying now. And you've done all that work just on that. So do you understand? The history has to be very important. In the First World War, the medics describe in the literature guys who had their arms blown off. And they carried their colleagues to the mobile hospital, maybe 100 yards across the trenches, and they didn't feel any pain. So pain is so subjective. It depends what the context is. If you're in a battlefield situation where everything's going on around you and everything's exploding, you're not going to experience the pain as when you're in a local factory and something happens to your arm and you immediately feel it. So everything is a combination of your history, your biology, your ability to tolerate pain, your prior history, and your constitution. So all these things factor into the subjective examination of pain. That's why it's an art and not a science. Medicine is an art, and it requires listening to the patient, understanding. A lot of it has to do with your spirituality. It's very interesting. We don't talk about that in medicine. But it actually has to do, very important. Those patients who are more religious are able to tolerate pain differently than those who are less religious. That's been shown by Benson at Harvard Medical School. So we know that your background, your socioeconomic level, when you're poor, you experience pain in a much, much worse way than when you're wealthy and you have a good insurance plan and everyone's taking care of you. That's been documented. So your socioeconomic background, your family interaction, your support, the people who support you in your family, all these things play a major role, plus your history and your socioeconomic history and your social history. All of this play a very important role, and you bring all that baggage when you come to see the doctor. So the doctor has to unpack and tease out all these different strands aside from all the objective testing. I want to end up by saying that we pride ourselves and we try and aim for, in this practice, a sense of compassion. Very often now in medicine, it's all just like get in, get out, do this, do that, you know, and it's all about the bottom line. Having gone through a serious car accident myself 3 years ago, and having seen the angel of death myself, I actually have absolutely no interest in doing this for economic profit. So I really enjoy what I do, and my staff enjoy what they do. So our only interest is your welfare. And if someone can't afford to pay, hey, you know, we take a lot of patients at no charge. We do pro bono work. We have reduced rates. We have payment plans. So that no one should ever say they couldn't come to us because of their ability to pay. And that's the hallmark of our practice. And I would hope that that compassion goes right from the front desk all the way through the care in our practice and even into the billing aspects of our practice. Compassionate care is the hallmark of what we strive, not always successfully, but what we strive to do.